For Global Medical News Network, this is Miriam Tucker reporting from the annual meeting of the American Association of Clinical Endocrinologists, Houston, Texas. I'm here with Dr. Francesco Rubino of New York Presbyterian Hospital and Weill Cornell Medical Center. This morning you spoke about metabolic surgery. How is that different from bariatric surgery?
Well, that's the question that everybody asks me now. I think it's an important difference. Bariatric surgery so far has been considered a surgical approach to obesity itself, and with the main aim of decreasing body weight. Metabolic surgery instead is an approach that aims at controlling the metabolic disease behind the excess body weight, and rather than just making people shed some pounds, if you will. And whether or not we can use the same operations that we use in conventional bariatric surgery, the aim is completely different. And that entails also the fact that we are basing our approach on mechanism of action that are metabolic rather than just mechanical.
So you've been doing metabolic surgery in patients with diabetes. What have your results been?
Well, the fact that diabetes improves dramatically after what they were considered bariatric procedures is well known since many years. What it was really known was the fact that this doesn't come just because of weight loss, as everybody thought before. But as I said, because these procedures basically change the anatomy of the bowel, which is a very important endocrine organ, and it's the organ that produces the most important hormones that are involved in insulin secretion and action. So metabolic surgery does change the physiology, and as a result the improved diabetes. Patients do extremely well clinically, but what it looks most important is the fact that their metabolic alterations are dramatically improved and sometimes completely resolved by the operations.
And you're using this in patients with diabetes who aren't morbidly obese?
When I was in Europe, we started to do some small clinical trials, and besides my own experience, there are many other centers where this has been done. And in fact, what the experience so far shows is that there is not a precise cutoff BMI that may predict when surgery can be effective. So there is a chance that we might help more patients than the one that have been referred to surgery so far, but I think we need more clinical trials to really define who is the ideal candidate for surgery.
I know that there is some opposition to what you're doing. What are some of the arguments you've heard, and how do you answer your critics?
Well, it's normal that you have some healthy skepticism, since, if you will, this is a complete departure from how diabetes has been treated so far, and there's no doubt that many colleagues or clinicians may feel like this might be too aggressive or maybe not even reasonable. But as a matter of fact, when you look at the mortality rates, the risk associated with the procedure, which should be always considered, they are favorable if you consider the morbidity of living with diabetes. So the idea is, okay, sure, we should not rush every patient into surgery, but when diabetes is getting out of control, and chances are that complications will come from diabetes, or even life expectancy is reduced and there is no effect from conventional therapies, well, having another option is much better than not having an option.
For Global Medical News Network, this has been Miriam Tucker reporting live from Houston, Texas.